We have a couple of minutes for questions and discussion, and I wish to take on the discussion from what we heard in your question and answer session. However, most of your questions that we have seen were unanimously answered. There's a strong feeling that Rituximab is basically improving the outcome in the first question, so there shouldn't be much of a debate. I think the principal question is how can we combine this now best, and I think Peter and Clemens have addressed this. And maybe I ask Francesc about his opinion. What would be your favorite comparative or combination partner for Rituximab in elderly or unfit patients?
Okay, let's, can you hear me? Yes. That's a difficult question because all the trials are ongoing now to define the best treatments for those patients. Maybe we have to take in account that we are still lacking a tool to define a specific comorbidities for CLL patients. CLL is different from other diseases. Patients are really immunosuppressed. Renal function is particularly important for fludarabine. So we are still lacking a specific tool for this kind of the disease. So when we have this tool, I think we will be in better shape to define the best treatment for those patients. On the other hand, we have interesting drugs. Lenalidomide is an important drug for patients, and MD Anderson is running a couple of clinical trials in elderly patients, proving that it's an active drug, well tolerated, that is not only active in CLL in elderly, but is even increasing immunoglobulin levels in more than half of the patients. So it's an interesting drug for those patients. So we are still, I think we have to define the better combination for those patients.
I have a challenging question to Peter Hillmen, because he was saying, well, we should use chlorambucil properly in elderly or unfit patients. Well, for the sake of a good discussion, I would say I strongly disagree, because in our trial we used the smallest, the lowest dose of chlorambucil, and yet it was not inferior to fludarabine. So in unfit elderly patients, achieving a CR or having an efficacious treatment doesn't really matter. The only thing you wish to achieve is symptom control. What would you answer to that? Because you play a lot. I mean, you several times emphasize, well, we need to give it right. You need to do it at a high dose. And I say, well, no, it doesn't really matter. What would you answer?
Well, it's interesting you don't think we should use chlorambucil properly.
Yeah, that's a clever answer. Okay, and what would that be?
I think the evidence we have in all the CLL trials, and most of them, of course, are predominantly with younger patients, but we have some emerging evidence in older patients, is the better responses lead to better remissions. And particularly in the elderly, and certainly in the data from CLL in the younger patient, your best chance of getting a durable remissions in the first approach of treating a patient. By treating patients and getting lower responses, you induce p53 dysfunction, potentially resistance to subsequent therapies. And the data we see from CLL4, from our CLL4, 30% of the patients were over 70. And the issue is salvage therapy, that you can't salvage the elderly patients as well as you can salvage the younger patients. So if you use inferior treatment, and in terms of response rate, then you've got a bigger problem, a sooner problem, trying to salvage patients. So if you're using lower doses or lower duration of therapy, you'll have a bigger problem earlier in trying to salvage them.
And I have to say, I do agree, because what we see from our data is, Clemens has shown this, most of these patients, even with comorbidity, die of CLL and not of related diseases. So I agree with you. Now a question to Clemens-Martin Wendtner. On the last part, there was, well, I think unanimous vote, at least in Europe, for chlorambucil being the favorite, maybe influenced by the presentations already. And there is still a 10% others. And after the last ASH meeting, one could say there's plenty of new drugs coming, some of them with very, very mild toxicity or even inexisting toxicity, kinase inhibitors. How would you speculate, let's say, on treating CLL patients with comorbidity in 10 or 5 years from now? What's your favorite for the future? Still chlorambucil, or do you think there are new things to come?
I think all of us, we would wish that we could skip the cytotoxic component of our treatments. And in line with this, I think we are now in the phase 1 investigations with these new drugs, with these tyrosine kinase inhibitors. I think 10 years ago, we didn't even think about tyrosine kinase inhibitors in CLL. This was just in CML. Now CAL101 and also these Bruton's tyrosine kinase inhibitors, very interesting drugs. And my vision, in answer to your question, would be to combine these kinase inhibitors with an antibody, for example. And then the question comes into play, what is the right sequence? We know from these new drugs that patients get a hyperleukocytosis when we treat them. So even the old-fashioned response criteria does not assess correctly responses, so they are underestimated with CAL101, for example, because you get the hyperleukocytosis at the beginning. So the future vision might be first use these TKIs, followed by an antibody, and most probably an CD20 antibody.
Kinase inhibitors. Any comment from other persons like Robin?
Can I try to tie together everything? Because I made some notes while we saw the comments through the keypad and the comments that came up here. If we tie everything together and start from the first question, the large majority agreed that Rituximab should be added to first-line treatment. However, as I mentioned, in the statement, the word elderly wasn't included. So then I would assume that people are thinking, as we would all agree, that for the young people, that is the combination. But the issue, therefore, is the elderly. And if we go back to the CLL8 trial, Clemens, you showed that the elderly fit can be included. But if you quantify that, it's 10% of the patients that, in fact, from your study, went into the trial. So that means that based on a physician judgment, the large majority of the over 70s were not deemed fit enough to enter FCR. I mean, not FCR, enter the protocol. There's a toxicity with the FC, as we know. So I think that is the second important point, that 90% of patients were not considered eligible. Then if we go to the final question, we read that in Europe, and there's also colleagues from, let's say, closely neighboring countries, chlorambucil still comes up as the largest utilized drug for the elderly. And putting that together with the fact that we know that, and we learned that 75% of patients over the age of 70 don't go into trial, it is clear that in the context of the Congress here, the issue of the elderly with CLL, which are the large majority, over 70, well, a large majority, let's say that that is really the clinical unmet need. So I think this we would probably all agree, that that is where we have to strengthen our clinical research. And that would also tie with what they're commenting now. I mean, do we need, for all these patients, chemotherapy? I mean, if we started to include maybe some prognostic markers, even in the elderly, we could one day maybe identify subgroups we could benefit either with new drugs or maybe only with antibodies. I don't know. I'm just putting this as a potential question. So
I would like to actually also, for getting a good discussion, I again challenge one of your statements and maybe go to one of the results we had, or I can actually mention it. 75% of you have never included a more than 70-year-old patient into a clinical trial. So the majority, and the other problem seen, or the same problem from, yes, this one here. You can also rephrase it by saying, well, usually we are not accustomed, we are not used to include patients of more than 70 years into clinical trials, because one of the things is the thing I want to challenge. The 70-year-old patient has a 40% or 50% chance, if not more, and Dr. Balducci's data early on showed this, to be physically fit, while we only have 10% of these patients in our trial. For selection criteria, bias of physicians, and all these things, it is not true that a 70-year-old patient usually is not fit enough. I mean, there's numbers showing that the go-go fraction in this 70-year-old group is about 40 to 50%. And we simply do not include these patients in clinical trials because we are not used to it. And I think we have to change the habit and improve. So my question would then be, maybe Peter, you want to comment and you wanted to say something anyway. How can we improve the recruitment and the performance of clinical trials in the elderly in Europe? What's your recommendation or idea about that? And I think you wish to comment afterwards. Okay?
I think we have to say that we have not had trials for the elderly group until very recently, and so that helps, having trials that we can actually recruit patients into, and then having acceptable treatments that in our previous trials you could only select the fit patients because one of the arms was very intense, and you couldn't risk them being randomized to those trials. I would take slight account with Robin's assessment of FCR, and we don't have a problem with younger patients. I mean, FCR is the best treatment at the moment, but 3/4 of the patients get through 6 cycles, 1/4 don't. And we're starting to see early relapses, and we have real problems with dealing with those. We're starting to see rictus transformation in more intense therapies. And so the new therapies that Clemens points out, which I think are very exciting developments in CLL, have the advantage that they're targeted, so they have less of the off-target effects that we're talking about, both for the younger and the older patients. And my experience of the elderly trials that we've done is that patients don't necessarily want to have 3 days intravenous infusion over a month when the alternative is an oral therapy. So the oral therapies are a distinct advantage, particularly as you're getting in the older age groups of patients.
Dr. Baldacci.
Thank you. I just wanted to comment something that Dr. Hallek said before, and I think is very important in the perspective of geriatric oncology. You mentioned that unless you treat the CLL right since the beginning with what you consider appropriate doses of chlorambucil, you may be dealing later with a disease which is much more difficult to treat. And that, I think, is something that we have forgotten in the discussion of geriatric oncology. In other words, cancer, all type of cancer, are dynamic entities that change as a result of our therapy, or maybe also on their own. An example that I was going to bring, but because of time I could not bring, is the example of prostate cancer. We used to think that, men in their 75 or 80 should not be treated for prostate cancer because they are not going to die of prostate cancer. That is true if those men are going to die at age 85 or 86 or some other disease. But if those men live to be 90 or older, many of them developed a Gleason 9 prostate cancer, which is rapidly killing. We have just discussed, there is a report on the last JCO about that, and I think that that may be the case in the hematological malignancies with CLL or with low-grade lymphomas. So I think I'm not ready to say that we should treat all of these patients aggressively because people can live longer. I just want to say a word of warning that if the people life expectancy keep increasing as it seems to be, we may be dealing with very aggressive diseases when we were thought that we were dealing with very benign diseases. Thanks for the opportunity.
Thank you. Now, we have a couple of more minutes, and if somebody wants to address an important point, please go to the microphone and ask your question. Identify yourself. Yes, please.
Marco Gobbi.
Marco
I've
Gobbi,
identified you.
Genova. When you speak or compare chlorambucil and FCR, you consider always the CLL8 schedule of FCR. But in an elderly patient, you can use also low fludarabine, oral fludarabine dose and together with cyclophosphamide. So you can obtain better results than with chlorambucil using lower dose of fludarabine and cyclo.
I would agree, and I let also Francesc comment on this aspect later, but the only point I wish to address is there's no real formal data on that. But in principle, you're right, there is a regimen published by Ken Foon in JCO and some others trying the same. However, the average age, again, the problem that we are discussing, the average age in this trial with an FCR light regimen with a lower dose of FC, as you suggest, is 60 years. In other words, I mean, I'm just saying the clinical research that we are doing in CLL is sometimes totally useless for the real patient population because they have comorbidity and they are older than 60 years. Again, but I think your idea is well taken, and that's what we think as well, to modify the existing standards to make them better tolerable for elderly or less fit patients. Francesc?
Yeah, I have nothing to say, nothing to add, because we don't have real true data on this trial. There was a phase 2 trial with 100% responses. So we have to check this combination in real elderly patients. We know that if you add more therapy, for instance, in the CLL8, when you analyze the MRD at 4 cycles and you compare MRD at 6 cycles, if you add more treatment, you are getting better responses. So, but we don't know exactly the response rate in elderly patients.
I think if you have no more questions, what I would like to suggest is to give us the chance. We have 5 more minutes to go approximately, to give the discussants the chance of having a final statement, including to comment on everything they want, except on non-CLL topics. So maybe, Clemens, you want to start, then Francesc, and we go just the way back.
Just before the final statement, to the person asking the question before, it's true that the mean number of cycles in the FCR trial in the elderly, this was significantly less. So this figure is true. But this was the reason why I pointed also out the Australian trial. I mean, this is an ongoing effort to define maybe a dosing regime for, I would call it not so fit, but they are not unfit, they are not so fit patients, somewhere in between an unfit and a fit one. Otherwise, I would say for myself, it's the main take-home message is that you should always assess in some way, whether it's a CIR scoring or something else. You should assess comorbidity. Do not judge on passport age, we have heard this morning. Then if you think it's an unfit patient, you should try to define a clinical trial. I think it's another message from this session that you should really seek for clinical trials. There are trials around, not only by the German or UK group, then you might also help the best your elderly patient.
Francesc?
Yeah, my final statement is that we have to learn that we have to extend our active treatments to elderly patients. So we don't have to think on age. We heard a lot during the session on that topic. So think on to extend active therapies to elderly patients and use comorbidity scales and include patients in clinical trials. I think it's important to answer the questions we are raising in this session.
To address the question of oral FC, we've used oral FC in CLL4, which is without the rituximab, and in our subsequent frontline trials for the fit patients, we've used oral FC, and we've dose-reduced patients. Creatinine clearance is a key part of the elderly assessment of CLL, and a lot of the patients can't have FCR for that reason. So we've dose-reduced. We've allowed patients to have FCR down to 30 mils per minute creatinine clearance, but dose reduced between 30 and 60 to 50% for the fludarabine, and that seems to be a safe and effective way to treat these patients. I think the other issue is that we're now starting to assess patients' biological criteria. 17p deletions, clearly not chemotherapy sensitive, and I think over the next few years we'll be doing more and more splitting of patients to more specific therapies, and we mustn't forget the elderly in that assessment of biological markers to direct therapy.
Robin?
If I may just take, again, a privilege just to tie up a couple of things, and then Michael will conclude. I think what have we been suffering since the Congress here is on the elderly, the fact that with the change in drug development in CLL, as in myeloma, we heard it this morning, in fact, most protocols have been designed, as a matter of fact, for younger patients and / maybe for fit elderly, but not very few have been designed for the real elderly, which are the majority for certain conditions. Only now we've gone into this issue and we're discussing and we've started to design. So this has been a problem, and I think this has to change. And in this respect, it's obvious that the definition of performance data should be included. It's not only defining age as it came up in all ways this morning, but we have to be much more precise to manage to include more of the elderly in protocols. So that, I think, is an important point. And in a line, obviously, of the elderly, the issue of compliance came out this morning, and this is very important because the elderly might be lonely, who's going to take them to the clinic, these very practical issues which are going to increase because the aging population is increasing. So the issue of oral drug is important, clearly. I would like to add that Rituximab is being developed in a sub-Q formulation. So that is another possibility, because if we could get oral drugs and sub-Q, that could, on the long run, make life easier, certainly for patients, but for us too, because, I mean, Rituximab has to be done in a clinic, and we obviously have problems with beds. So that, I think, in a way ties up. A final point, and I'll give back to Michael, which came to my mind. I had it in mind earlier, then it came back to my mind when Clemens mentioned tyrosine kinase inhibitors. And I'll tell it to Gordon, who's right in front of me. We don't have ALL in the program. Now, I'm saying this because I don't know if Gianni Pizzolo is in the room, but I mean, I just to remind everybody that in the era of molecular biology and subdivision of patients, I mean, the Philadelphia positive ALL was the worst condition that we could ever diagnose. I would say not only in hematology, but in cancer and maybe in medicine. Now, with the tyrosine kinase inhibitors, we can put patients with Philadelphia positive ALL in remission, even in the 70s, 80s, and even 90-year-old. Gianni Pizzolo in Verona, and we discussed it many times, a patient was 89 with ALL. Luckily, he was tested for the Philadelphia, because in the Jimema network, this is done. And then, since he was luckily positive, he was put on imatinib and went into remission. He turned 90, driving a car and conducting a very good life. We have films of him, pictures, we don't have time here. He was put on second generation dasatinib, went into second remission. He turned 91, he died 2.5 years later. Now, this is one case, but it's not the only one. And I would like to add that all patients go into remission with tyrosine kinase inhibitor, irrespective of age. And I would like to add one final point, is that over 50% of the over 60s with ALL have the Philadelphia chromosome. So this is extremely important that we test them and we treat them even without chemo. So there's something for the next meeting, Gordon. I think you might consider that. So I say that, and I give it back the word for the final conclusion to Michael.
I wanted to think, but I have to make a very, very concise remarks I try. I think we have to solve for this entire field, and at this meeting, hopefully, there will be some recipes for that. If you talk about kinase inhibitors in 90-year and older patients, the expenses and the cost issue will be a topic, and that needs to be discussed. Another point that I really am concerned about is the standardization of the assessment. If we do clinical trials and if we do the assessment, we need to have a consensus, some kind of an agreement how to assess them with a minimal set of data, because a real comprehensive geriatric assessment is something that really requires physician time or caretakers' time, and we never will be able to assess that as systematically as in a geriatric unit. So there needs to be some guidelines for that. Otherwise, we will have all kinds of totally different assessments, and we will never be able to compare different trials and results in even CLL in one disease, and I'm not talking about different diseases. So these were the concerns I have for the future. With this, I thank the speakers, the discussants, and the organizers for giving me the opportunity to chair this meeting. Thank you very much.